I want to welcome you to the fourth webinar in our series, Diabetes and Metabolic Syndrome, and it's with Cynthia Moore. Cynthia brings so much information about this topic and knowledge, and hopefully you've had a chance to read her bio on Canvas. Um, there's so much to love about what Cynthia is going to share with you today. She was actually one of the first co-program directors for this program, and she's just been wonderful to work with. So it's always a wonderful pleasure to welcome her back. But before I turn it over to Cynthia, I want to give you your first key word. That word is prevention. Prevention. Okay. And with that, I'd like to turn it over to Cynthia Moore.
Well, good morning, and it is my pleasure to be with you. I'll pull up the first slide in just a minute, but wondering before we start, are there any things you're hoping for in this webinar that you'd just like to put if we had a kind of a whiteboard and you could put things that you hope we circle around to? Anybody have things like that, just so that we come back to them if we can? Not so much. Okay, well, we'll dive in. I am going to share my screen. Part of my why is that as a person who's been in the health field for a while, self-care is really important to me. And one of the things I'm hoping you will take away from today is not only understanding that it's a continuum of that's movable for people who have pre-diabetes or metabolic syndrome or diabetes, that's a kind of a continuum, and you can modify that with, for people with type 2 anyway, you can modify it with various aspects of lifestyle. It's possible to reverse it or prevent it from moving into diabetes. Another kind of, but the self-care piece is what I want to just touch on for a minute. Part of why I became a health coach, became a dietitian, became a diabetes educator is because I witnessed as a child the difference that self-care made in the life of my mother, more in the realm of mental health than physical health in her case. But I saw where a change in diet and movement and spiritual practice made, and community really made enough of a difference that instead of in and out of the hospital or um, with very kind of dramatic mental health consequences, she became happier. It affected our whole family life. And the difference wasn't the medications, it wasn't who was diagnosing her, it was the self-care piece. And so I was naturally drawn to nutrition, and then as a registered dietitian, realized in diabetes care, they actually had a whole series of things that they educated people about, and even Medicare and other Blue Cross and other insurers pay for. And you and I will talk about those as the 7 diabetes self-care skills, and we'll see some of those in action today. Um, but I then was very receptive by the time I'd worked in those arenas for a bit, and then I found the health coach training program at Duke. And as Rita mentioned, was also fortunate subsequently to that to be involved in the very first cohort and the very first classes at Georgetown. So I'm delighted to be with you, and I hope, in addition to those things, that you also take away a sense of knowing enough about the terms related to diabetes to feel comfortable in some clinical settings, patient care settings, and that you recognize where your skills as a coach are going to fit in. So in terms of self-care accomplishes what no medical care can, that's kind of something I've seen over and over in action. I've worked in healthcare systems with people in all stages of obesity, prediabetes, metabolic syndrome, diabetes, and then the outcomes after that for people. And so I'm a big believer in, yes, the self-care, but also the group. I've seen people who might struggle on their own do very well in a group, like a prediabetes 12-month. Today, they're available around the country. They're called Diabetes Prevention Program. groups and even a shorter one. This was an example of a group of people who were in an 8 weeks to wellness class that we'll talk more about at the end, where it was just 8 weeks. And we just touched on a few aspects of diabetes self-care, but more used a coaching approach with them. And they had the benefit of learning from each other. So the power of the group is really another key takeaway that I have at least experienced, and I hope to kind of share with you. Where are we headed today? We're going to look, start, of course, with Cura Personalis, that place in a sense of connection within and with wholeness, that no matter what's happening in mental or physical health is still there. And part of our benefit as coaches may be to be able to enhance that for some of the clients or folks that we partner with. We'll touch on terms and how often diabetes occurs, or what's the so-called incidence of it. And then that progression that I mentioned from some of the factors that can lead up to the stage that we call pre-diabetes and then diabetes. And we'll talk about foundations for health. They're not too different for someone dealing with diabetes as they would be for others, but we'll touch on those. And in the diabetes realm, they have a name for that, the Diabetes Self-Care 7. You'll know those by the time we finish. And then a little bit about resilience, and importantly, how do people know when they're kind of getting into the land of concern, and the benefit of knowing your numbers if you happen to be a patient or a client. And for you as a coach, the importance of knowing what certain numbers are if you want to partner with people who have chronic health conditions. It's pretty helpful to know the fasting blood sugar and the what we'll talk about, the 3-month measure of blood sugar called a hemoglobin A1C. And then a little bit about group coaching, and you'll have a chance kind of towards the end to prepare for what could be a first in a series group health coaching. I believe that Rita is going to share this video with you so that I don't lose connection to slides. So this slide, you'll see kind of defines the types of diabetes, and it's pretty concise and good. I think you'll enjoy it.
What is diabetes? Diabetes is a serious condition where your blood sugar levels, also known as blood glucose levels, are too high. It's diagnosed from a blood test. There are 2 main types, type 1 and type 2, which is the most common. And lots of other types like gestational diabetes, type 3C, and MODY. The causes and symptoms depend on the type of diabetes you have. Diabetes happens because of a problem with a hormone called insulin. When you eat or drink, any carbohydrates you've had are turned into glucose, a type of sugar. Insulin acts like a key to unlock the cells to let the sugar in, to give you energy. If you have diabetes, this can't happen, so sugar builds up in the blood. High blood sugars over time can cause problems in almost every part of your body, from your brain to your feet. So treatment is about trying to keep blood sugars within a target range. Being as active as possible, eating healthily, and going for regular health checks will help you do this. Some people will also need to take insulin or other medication and check their blood sugars regularly. Lots of things can affect blood sugars, so it can be tricky to balance. But it's possible to lead a full life. It's about being in tune with your body and learning what works for you. You can get more support from your medical team and us here at Diabetes UK.
Thank you, Rita. So that's just a brief overview. Any questions about those kind of types before we go further? As they mentioned,
Yes, I have a quick question, if I may.
Sure.
Type 3, and there was another type that I was trying to write down, but it was very fast and I couldn't get it.
Type 3 is used in a variety of categories. I don't know that it's in this country. I don't know that it's actually part of the standards yet, but it's often used to kind of describe the cognitive effects or the brain effects of blood sugar that can result in, for some people, in dementia type things. The other one that was up there, I think, was MODY, which stands for maturity onset diabetes of youth, and it can happen in adulthood. So that's, sometimes, and I've worked with people who appear to have type 2, but it's actually more like type 1. And that turns out when they really drill down genetically, it's MODY, or maturity onset of what appears to be type 1. So,
Thank you.
yeah. So let's see. I'm going to go back 2 slides and see where we are here. And sure which of these I left off on, but we'll start here. Okay, so gestational diabetes is the other one, which is the diabetes that occurs during pregnancy. So type 1 is only about 10% of the population of people who have diabetes. 90% of the people in at least the US that have diabetes, it's type 2. In type 1, it's a condition where the body requires insulin. That's the treatment. In type 2, it's more of a lifestyle related disease. So things like diet and exercise are very effective in helping to reverse prediabetes and diabetes. Gestational diabetes, while it happens in pregnancy and is therefore short term, usually for the person who has it while they're pregnant, it does put the mom at an increased risk for diabetes down the road. So it's important to know that. If somebody has had it in their past, it puts them at a pretty significant increased risk for developing diabetes. When you think about a iceberg, you may think like I do, okay, we see a little bit on top, but there's the bigger part is down below. You might not see my arms here, but that's the much bigger chunk is what's below the surface. And that's why I use this slide with talking about how many people have diabetes. Right now, it's 40 million people in America, about 12% of the American population. Most of those, again, are type 2, the lifestyle-related diabetes. And the bigger issue is all this that's underneath the surface that's forming that progression that I mentioned. It's 115 million, or 38%, almost 40% of Americans have prediabetes, meaning their numbers would indicate that if they do nothing different over the next 10 years, and for some it'll be 2 or 3 years, some it'll be 10, they will develop into diabetes. And the real problem with diabetes isn't so much the condition, it's that once you've had it, or once you have it, and it sticks around and your blood sugars stay high, it results in, it puts you at higher risk for many things. We're going to lump them together and call those diabetes complications, and we'll talk more about them. The other thing is for seniors, it turns out many years ago when I lived in West Virginia, the statistic was half the seniors in West Virginia had diabetes, had type 2 diabetes. And now it's half of Americans, basically 51%, half of all seniors have type 2 diabetes, or prediabetes rather. So it's and the reason you see those arrows is when I gave this talk in January, or a version of this one to your cohort 17, the earlier numbers were 38.4 million, and now it's 40. That's partly based on new information from the Centers for Disease Control. But you see why we talk about it as an epidemic. Not only is there a lot of pipeline and prediabetes leading into that, what we see above the surface of diabetes, but also the numbers are growing really fast. And so the other concern is that we didn't used to see type 2 diabetes in children or teens, and that's people under the age of 30 or 31 are among the fastest growing group of people with prediabetes, which means, of course, that they will get diabetes earlier than people historically did. So I thought one way for me to meet the aim of having you feel more comfortable with terms would be to put you to work a little bit on these terms. So I'd love to get some volunteers, and here's what you'd be volunteering for. You'll see some terms that are going to be highlighted in a minute in a yellow highlight. And those terms, I would love to have each of you sign up for one that you would just take a minute and look it up on Google or somewhere and see if you can kind of find the definition for it. And then when we get to the slide where we're talking about that term, I'll invite you to share what you found. Does that sound okay? Okay, so when we get to those slides, they'll usually have this orange kind of thing here, but so metabolic syndrome, insulin resistance, prediabetes, hyperglycemia, and then complications of diabetes. So who would like to sign up for, let's start at the top, metabolic syndrome. Okay, thanks, James. And how about insulin resistance?
I will.
Okay, thank you. Do you prefer Damaris or Dee Dee?
Dee Dee's better. Thank you.
Okay. Okay. And how about prediabetes?
I'll sign up for that one.
Okay. Was that Carrie?
Yeah.
Great. Thank you. And how about hyperglycemia?
I'll sign up.
Okay, Sheila, thank you. Hyper. And then complications of diabetes.
I will, please.
Okay, thank you. Am I saying it right if I say Suleiman?
That's
Suleiman?
right. Yes.
Okay.
Solomon.
Suleiman. Lovely. Thank you.
Thank
And how about diabetes self-management training? That's the abbreviation DSMT. Do we have anybody else who's willing?
I can do it.
Okay, thank you, Patricia. And how about either CDE is the old name, CDCES is the newer name, but the Certified Diabetes Care and Education Specialist. Do we have another? If not, I'll do that when we get to it. Okay, so before we leave this, it's generally recommended that we use the term persons with diabetes rather than calling somebody diabetic. So the person first language would be a person with diabetes. And in the medical literature, you would see that possibly as PWD or persons with diabetes. I'll define hypoglycemia. Some of you probably know some medical terminology, but for those who don't, which would have been me a few years ago, hypo means low, glyce or GLY, the middle part of that word, glyce means sugar, essentially, or glycemia, and the emia is in the blood. So anytime you see that emia, it's going to mean in the blood. So hypo would be low sugar in the blood or low blood glucose. And it's a dangerous condition, especially for people with type 1. People with type 2 are not so likely to encounter it, but you might have seen in that video where the way we manage diabetes is to keep blood sugar in a fairly narrow range, especially for somebody with type 1 who's taking insulin. And then the last CDC, the Centers for Disease Control. And maybe I'll just define CDE was Certified Diabetes Educator. A few years ago, that name changed to CDCES or Certified Diabetes Care and Education Specialist. And those are people who could be a therapist, could be an exercise physiologist, a physician, or a registered dietitian, a nurse, another like a nurse practitioner, somebody who has a field of their own, but they have specially trained and had experience working with people with diabetes, and they can sit for the exam and become a certified diabetes care and education specialist. So they are often people, RN, CD, CESs are often the people who are educating in a hospital or a clinical center or dietitians with that background. So a little bit of a history lesson here. I'm old enough to have been a part of this living history. Um, and this guy over on the left, Dr. Raven, he was a good clinician, and he was observing that people who had more of an apple shape to their body than a pear shape, and people who had high blood fats called high triglycerides, and people who maybe had hypertension, that those kind of things often went along with the blood sugar going up, and those kind of things often went along with somebody developing heart disease. And so in 1988, he proposed a term called Syndrome X, wrote a book about it, and said, I think we're waiting too long. If we wait till somebody's blood sugar is really high, there's a lead time in there that we could be, as healthcare folk, intervening earlier. And by the next decade, they'd retermed it and called it metabolic syndrome. And the World Health Organization said, okay, here's the definition. And it's still the one that's used today. There are 5 things. And if you have any 3 of those things, chances are good you have what gets called metabolic syndrome. But metabolic syndrome and prediabetes have a lot in common. So as you can imagine. And so these are the 5: high or elevated blood pressure, elevated blood sugar or blood glucose. Glucose is the more technical term for blood sugar. Excess waste fat, and that is measured by a tape measure around the middle. And then low healthy cholesterol. There's a high density lipoprotein or HDL cholesterol. And that one you want higher. And if it's too low, that's a problem. And then high triglycerides. Triglycerides are a fancy name for fat. And we don't want a whole lot of, just like you don't want a lot of fat roaming around in your kitchen sink, going down the pipes, you don't want a whole lot in your pipe system either. So if you had any 3 of those, you qualify, and you still qualify today for metabolic syndrome. Who had insulin resistance? I think that was, did I just do 2 of these? I just went over them. Okay, James, I'm going to let you share what you found about metabolic syndrome. Sorry, I was forgetting this was an orange one. I should have put.
It's okay. I'll take it from here. Thank you. All right. Metabolic syndrome isn't a single disease, but rather a cluster of risk factors that raise the chances of developing heart disease, type 2 diabetes, and stroke. Here's a breakdown of the 5 key points that define it. Core definition. It is diagnosed when a person has 3 or more specific metabolic risk factors occurring together, which dramatically multiplies cardiovascular and diabetic risk compared to having just one factor. The second one, abdominal obesity. A primary marker is a large waistline, specifically a waist circumference of 40 inches or more for men and 35 or more for women, indicating excess visceral fat around internal organs. I think that's a key factor. I remember hearing that somewhere, that is where that fat is. That's really important. Insulin resistance, and third, insulin resistance and high blood sugar. The body's cells don't respond properly to insulin, which is sugar, leading to elevated fasting blood glucose levels, 100 mg/dl or higher, or pre-existing diagnosis of type 2 diabetes. Fourth, unhealthy cholesterol levels. This includes a combination of high triglycerides and low HDL, which is considered good cholesterol.
Mm-hmm.
Under 40 mg/dl for men and under 50 mg/dl for women. And last, elevated blood pressure. Consistently high blood pressure defined as 130/85 or higher, or being on medication to treat hypertension which strains the heart and damages blood vessels over time. So, and I got help from Gemini.
Thank you. Thank you. And thank you for sharing those numbers, because those numbers, well, our aim for you at Georgetown is to become the kind of presence and coach that allows people to move forward in your lives. If you decide to take the exam, those numbers are important to know. So the number for what is the waistline number, what is the HDL cutoff. You don't need to know them now, but it was nice to have you give them a foreshadowing, James. Thank you so much. And let's
You're
see, I
welcome.
think Dee Dee, you were going to share insulin resistance, and here maybe just bottom lining best you can, because it could be a big topic too.
Simply put, insulin resistance is a condition where your muscle, fat, and liver cells do not respond effectively to insulin. Some of the symptoms are energy crashes, weight gain, unusual hunger, and skin changes, which people develop those velvety patches that we see a lot of times on their armpits, necks, and on your the darkened skin, and you see them usually on people's calves. Some of the causes and risk factors are excess weight, lack of physical activity, poor sleep, high stress, diet, and age.
Thank you. Thank you so much, Dee Dee. Yeah, so this is Dr. Raven was paying attention, and he was noticing, and it's a good thing, because consistently what's happened over time is the numbers that we call diabetes numbers are much lower now than they were back when he was before he started to hit the drum that we need to be intervening earlier. And so hopefully we're catching people sooner, and you as coaches won't necessarily be able to assist other than to help with readiness, be that safe landing place for people to feel their feelings. And just because you know what might be good for them doesn't mean they're going to be interested in that as their health behavior change, as we know. But your presence, your coaching skills have a lot to do with how well they feel and how supportive small action steps can be. So can be very, very helpful. So there are some antecedents or triggers that make insulin resistance more likely. Those are the things in red. You've already heard about those: the lack of exercise, the adipose tissue being larger in the middle, with visceral adiposity is another word for that. Smoking. Dysbiosis is when the intestines aren't filtering, they don't have tight junctions, and they're not filtering like they should be. Some things slip through that shouldn't, etc., and cause inflammation. And then inflammation can cause more dysbiosis. But all of those things in red can be, as well as chronic stress, can be contributing to insulin resistance. When the body is resistant to insulin, part of what the body does is then try and put more insulin in to help shove things into the cell. And that doesn't work too well usually. So the best is to get at some of the root issues, and we'll talk about those in a minute. But the downstream effect of insulin resistance is, as you see it here, type 2 diabetes, hypertension, some hormone imbalances, even cancer, we think now is partly related to insulin resistance, and how the body handles blood sugar, and certainly fatty liver. So you've seen this before. What do you remember about it? This illness-wellness continuum. Is it looking familiar?
Like the difference between health and well-being or wellness.
Yeah.
Mm.
The difference between health and well-being. Is there more you want to say about that, Suleiman?
Yeah. Yeah, what I understand that health is the absence of disease, and wellness is more uh, like what positive things that goes beyond health.
Yeah. The positive things that go beyond health. Yeah. And so a lot of what medicine looks at is that left-hand side. They call it the treatment paradigm. And what Dr. Travis, who came up with this visual that I think is very useful, reminded us is there are two poles here, and just because you don't have a disease yet, that's not the whole story. You could be aiming over here for high-level well-being, and that the steps there of awareness, education, and growth can help no matter whether you're over there kind of with a chronic health condition already over on that left-hand side, or whether you're, whether you're not, that the wellness paradigm goes the whole distance. That's, to me, one of the things that this says. So we know that somebody could be at that neutral point and not be aware that already they've got some high blood pressure, they've got some elevated blood fats, or they might be aware they've got some extra pounds, but not think too much about it. And by the time they're over here at symptoms, things that the doctor might be seeing as well, they might be kind of well over into this range, moving in this direction. And then by the time diabetes is diagnosed, it might seem like a surprise. There's been many people when I worked mostly as a dietitian who would turn to me and say, why didn't my doctor ever tell me I was, pre-diabetic or whatever. So you will encounter that as well, where the person may not even realize they're in a pre-diabetes state because, yeah, the conversations with the physician may not have included letting them know they're kind of in this, what I would call, important zone for making change if they make it soon enough. And the good news is that by making some changes, we know that it is possible to instead be moving over here, no matter where the person is, whether they have diabetes, they have pre-diabetes, or they're in that sort of neutral zone. That more activity or movement, even standing instead of as much sitting as we do, is helpful to allowing the muscles to use glucose and therefore lower blood sugar. And a little weight loss turns out to also help open the door of the cells and allow the glucose to come in without as much insulin. So it reduces insulin resistance. And that there's a progression. So in early stage, it might be all quiet on the open front. The person hardly knows they have anything going on, but by the time it's down here at the advanced stage, they might be even having complications of diabetes before they notice that there's a problem. And so our aim in healthcare in general would be to share the good news that you can move towards that high level wellness at any stage, but also that if you implement sooner over here at this intervention point, you can, we know through large studies that you can actually change things very significantly and prevent prediabetes from moving to diabetes. You can move out of that zone. I'm going to show you a bunch of pictures real quickly. This is, as you can see, a lot of states in the United States, and this was from the year 2017 to 2019. The things in green indicate these are parts of the country or states where less than 25% of the population in that state is obese. Obese is defined as a body mass index of 30 or above, and generally means they've got at least 30 pounds to lose. And so Colorado, California, whatever, Hawaii, and DC were the only ones in that time period that had that low a rate. By the time we're up here in the yellow, it's less than 30%, meaning 30% of the people in these yellow states were obese, and more like 35% for the orange, and higher than 35% for states like Oklahoma and Arkansas and Kentucky and West Virginia. So this was for non-Hispanic white folks. This is for Hispanic folks, same time period. So you haven't had class 5 yet, is that right? In class 5, you have had class 5?
No.
Oh, okay, it's coming up. You'll have a whole section on what are called health disparities, but this is part of how this plays out, right? There might be less access to green space. There might be different levels of access to fresh food and things like that. You can see there's a whole lot more red, meaning states where a lot more of the population is obese. And this is for the same time period in the Black population. Um, these are growing quickly. It's not my fault. I don't know how to make them slow down, but you can see, you see what I'm seeing, right? So these two slides on the left, this is the obesity rates in 1999, similar color coding. And this is the diabetes rate. So the diabetes rate is a little behind the obesity rate, but you kind of see the states where things are lighting up on the left. They're more likely to be lighting up on the right, given a few years later. And here we have the same thing. So that's 16 years difference. When I talk about an epidemic, you see why, right? This is not good. This is not good. We're not alone in the world. Unfortunately, there are many countries where people eat a more Western style diet and they're having the same kind of effect on their health. So these are the risk factors for prediabetes. If we can intervene there, it's like we only have to make a little bit of a course correction and we can head back towards health. But if we wait till we're way over into the realm of diabetes, it's a little bit harder of an adjustment. But even then, we can still head back towards health. But being sedentary, overweight, high blood pressure, aging, and many of us have that where mother, father, or siblings have diabetes, chances are our risk is about 40% higher than the other folks who don't have that particular risk factor. And then that low HDL that James was telling us about, when that healthy cholesterol is low, it's a risk factor. So lifestyle does make a big change. Here was the big study. It was called the Diabetes Prevention Program, and they first published in the year 2002. It was supposed to be a 5-year study, and here's what they did. They took people from not just Johns Hopkins, but several other sites around, and if they fit the criteria for prediabetes, they randomized them, meaning half the group went into the group that got a medication, one of the medications that's sometimes used in early stage of diabetes called metformin. And the other half got a 16-week lifestyle intervention program, or 16 sessions that was weekly or every other week, and then it went to monthly, but where they were given tools to support them getting to move more and to make some dietary changes resulting in some weight wellness or weight loss. And what they did was they found both were helpful. This group over here, the metformin group, they had only 30%, they had a 30% improvement or reduction in people moving from pre-diabetes to diabetes. But over here with the lifestyle program, and this is why they stopped the study early, was because 58% of those people who were getting those lifestyle support things were able to not progress from prediabetes to diabetes. So they recognized movement, weight loss, a little change in diet has a pretty profound effect. Make sense?
Yeah.
So they stopped the study early because it became clear 30 versus almost 60% improvement for this group that had the lifestyle intervention. So the good news is you're learning all about how to support people through modest changes in lifestyle. I want to switch gears just for a minute. Right before I shared this webinar, probably a few years ago now, my husband and I were walking in the woods, and I noticed there was a line of trees and there were these odd bumps on the trees. And so I started paying attention, and I noticed there was like old barbed wire, like it was old anyway, there had been some development of a long time ago. And these odd bumps, I looked closer and noticed, you might not be able to see it, but there's a piece of barbed wire coming out of this tree right over here. And the same here. You can see these three kind of bumps. And this one, it's more clear. You can see the barbed wire here. This tree had grown up around barbed wire, which to me it was a good sort of simile, I guess, like trees that can adapt and heal around damage. I've seen people do amazing things when they set their mind to shifting for chronic health things. And so these are some of those things that we know or make it very possible for many people to improve their blood glucose numbers. If they move enough, like 30 minutes most days, they will get for 5 days of 30 minutes, they'll get 150 minutes a week of movement. And that movement is enough to turn the needle back from pre-diabetes to health or from diabetes back to pre-diabetes. And that matters. And that losing even a little, like 5% of a person's body weight, for some people can normalize their blood sugar. And in part, it makes the cells more sensitive to insulin, which is really what you're wanting or looking for. So we can all check our BMI. Most of us here asked who thinks they're maybe, have that extra weight around the middle or extra weight period. Maybe most of our hands would go up because we live in America and this is how it is for those who live here. But
Same in Kuwait, Coach. I was seeing the ranking, like Kuwait and America are number 1 and 2 in the top list. So,
say it
in the
again.
obesity, I was looking at the ranking of obesity percentage in population.
Yes.
Kuwait is 38% of population are obese, and America is around also 38.2 like this. So with different population, but the percentage is we are the same. Yeah, and in diabetes we are a bit higher. We are like 25% of people here are diabetic. In America, I think it's 14%.
Yeah, I think it's more like 12%.
12%, yeah.
Challenge is not everybody that has diabetes knows it. And not everybody that has pre-diabetes knows it. So you're saying in Kuwait it's 14% diabetes?
25%.
Oh, 25%. Oh,
yeah, 1 out of 4. Yeah, it's pretty high.
And is that for all adults or?
It's all. I think it's all population. Yeah.
All population. Wow. Okay.
Yeah.
Hopefully you'll decide you're fascinated by this topic and you will
of course.
added training to work with teams. I'm going to show you how
Thank you so much.
fit into teams. Because it is epidemic. And thank you for making that addition that it's not just in the US. It's mostly developed.
Thank you.
So I know Mary Lou Perry probably has already talked with you, and she probably mentioned BMI maybe not the very best measure of obesity, and that's true, but it is one that we have. And it is true, generally speaking, that if we can get our body mass index down under 27, ideally down towards 25, that the risk for diabetes does go down there if possible. We're going to hear here from somebody who did put his efforts in to turn it around. Here we go. It's Patrick.
When the diagnosis came, I do have there's a history of it in my family. I don't think that I was particularly shocked to hear it. You begin to give that a priority that's a little bit different. So you look at, you start reading nutrition labels, you start bringing in, you start looking for fresh vegetables. Fortunately, in the area where I live, in the summertime, there's a lot of fresh vegetables around here. When I went to that first appointment, one of my reasons was because I wanted to exercise again. And I just felt that at 47, I should check with the doctor before I did that. You know, my primary form of exercise has been running, and really, you can only do that for so long, realistically, most people. And so, more resistance exercises is got to be added, the increased exercise. It's a great stress reliever. At least I could start by walking, And now, so that was 4 months ago, and I ran 5 miles yesterday. So, if you want to call it a short-term goal, is to at least cut my dosage of my medication. I'd like to be off it completely. Based upon my most recent numbers, or the progress, actually, not the numbers themselves, but the progress in between the 2 points, my doctor feels that there's a good chance that I can manage the diabetes without medication, which is really what I want to do right now. Obviously, the diagnosis, the diabetes doesn't go away, and a lot of people have said, this may have saved you. The diagnosis may have actually been what keeps you alive. And at this point, I know that I've proven that there's something I can do about it. So, it's not a waste of time. It's not something that is just, all this stuff is not something that is just pie in the sky theory. It's the numbers prove it out. My chemistry proves it out in my own little chemistry set. And the numbers show it.
So Patrick had the opportunity to use his numbers for some feedback, right? And you will likely have some clients who may find that pretty useful and motivating also. It gives them something discrete to pay attention to. Any comments on that before we go forward?
I like that he said diagnosis that saved his life. Oh, that's so true.
Mm-hmm.
Yeah.
But this is James. I think something that I'm going back to with Suleiman, what came up for me is this. What's healthcare look like in Kuwait? Does everyone have access to healthcare if they want it?
Yeah, the healthcare is free, for all citizens, and also for foreigners. It's very fraction cost, but the food here is excessive. Delivery and food, yeah, it's
So for
extra.
me, I'm thinking along the lines of then the data you have is pretty straightforward for those individuals. If they want it, they have access. So then those numbers seem pretty true. Whereas here, because we have a lack of disparity on people having health care, and then as Cynthia said, not even knowing if they do, then our number could actually be much, much higher because we got people walking around because they don't even have access to healthcare
Mm,
to know that. Whereas in Kuwait, everybody's got that wants it has access to healthcare. And
that's
then
totally true.
and then in the last video, then it comes back to again where we talked about like maybe 2-3 sessions ago about food deserts, disparity. Um, I'm fortunate I have access to farmers markets, but I also have transportation as well. So if I can get to if I want to get to those farmers markets, then I have access versus individuals who wouldn't. So it's just a whole bunch of things are popping up for me right now, including my own health challenges that I've had in the past around diabetes and my A1C being really high because of other comorbidities as well. And then I'll check out.
Thank you. Thanks, James, and thanks, Suleiman. And yes, it would be really fascinating if we had the capacity to know what the actual incidence is in the US. I mean, I'm sure CDC, tries to keep up, but it could very well be as high as it is in Kuwait. So one of the ways that people manage that is very, very helpful is, as you heard on that very first video, it's to a large degree, it's the quality of carbohydrate and the quantity of carbohydrate that hits the system that is part of the challenge. So you've been introduced, I believe, to the plate method, the idea that if half the plate are vegetables, especially the non-starchy vegetables, and a quarter of the plate is the lean protein, be it chicken, fish, or what have you, or a plant-based protein, and a quarter of the plate is the starch, that's a pretty easy meal planning method. Not that we always sit down to a meal, etc. But even if it's a bowl, if that's the proportion, that's pretty helpful in terms of the what is in the bowl or on the plate or what have you. It turns out that the Mediterranean diet does show it confers benefits both for the heart and blood sugar and brain and our ability to have clear thinking, all of it. And what all those kind of Mediterranean diet countries seem to feature, right, is the fruit and vegetable, whole grains. And this is one way to look at how close is my diet to a Mediterranean diet. You could take a moment right now and sort of assess, give yourself a point for every one of these that you have. So, if you're getting 2 cups or more of vegetables a day, that would be a point. If you're getting 2 small pieces of fruit a day, that would be a point. 2 a whole grain, etc. But what most of them don't have a whole lot of is the added ultra-processed foods that we're eating. About 60 to 70% of our American diet, and probably somewhat in even countries like Kuwait, are these ultra-processed, mostly industrially made foods that really don't look like what you'd find at the farmer's market or the regular grocery produce and meat section. So the other thing is for diabetes, it's very helpful if you pair a protein with some healthy fat, like an olive oil or an avocado or something of that, nuts, even if you add it with the carb that you're consuming. And the carbs here, who wants to call out which of these categories would be mostly carbs? Anybody? Fruits, whole grains.
Whole grains, vegetables.
Even some vegetables, right?
So vegetables are mostly carb, but there's hardly any carb in them if they're a lettuce or a green bean. By the time they get to be a potato or like that, yes, there's quite a bit of carb there. So yes, those vegetables would, like a sweet potato or white potato. Fruits are mostly carb, whole grains are mostly carb, but what do all 3 of those have that a highly processed snack food like potato chips is not likely to have? Potato chips, yes, is sort of a vegetable, but compared to the baked potato and the potato chips, there's going to be a lot more fiber in the baked potato than there will in the potato chips, right? For the calories, etc. So the foods with fiber are really helpful as the kind of carb that we consume, and then the lean proteins and the healthy fat that you pair with it at the same time helps keep the blood sugar stable instead of those big peaks and valleys. And the stable blood sugar usually cuts down on cravings as well. So again, no one right diet. We have certainly moved through lots of different meal planning methods. The dietitians of the world have over the last 30 or so years of working with people with blood sugar, but we know that the quantity and the type of carb do count, and whether there's protein and fat with it, all of those count. So some other things that we think are important to know is what are the blood sugar numbers? And we think it's important for patients to know and understand their numbers, we being people who want them to get better. And so for you to know the fasting or first thing in the morning blood sugar, just as I think it was James noted, anything that's higher than 100 to 125 would indicate pre-diabetes for the fasting. And if it's 126 over twice at least, that's a diagnosis of diabetes. For the 3-month measure of blood sugar, they can actually take a test that measures the sugar in your red blood cells. And red blood cells live for 3 months. So this is an average of morning, noon, and night for what the blood sugar's been. And normal would be, it's called the hemoglobin A1C test. And less than 5.5 would be the aim. Make sense? And so encouraging people by perhaps just asking, do they know what their numbers are? And if not, inviting them to learn those. Who had the, let's see, who was going to go for hyperglycemia? I think that was Sheila, maybe?
Yes, it is me. Sheila, let me bring that up. Bring my notes. Okay. Hypoglycemia is the medical term for high blood sugar. It occurs when the body lacks sufficient insulin or cannot use it properly, causing sugar to build up in the bloodstream. It is most common in individuals with diabetes. The causes, hypoglycemia usually develops when blood sugar rises significantly above target ranges. And common causes include missing medication, skipping or forgetting doses of insulin or blood sugar lowering medications, diet and exercise, eating an excessive amount of carbohydrates, or failing to get enough physical activity, illness and stress. The body's stress response to infections, surgeries, or other illnesses can raise blood sugar, even in people without diabetes, and medications such as steroids, prednisone, or other treatments can spike the blood glucose.
Thank you, Sheila. Yeah, so hyperglycemia, high glycer sugar, emia in the blood. And we used to think it was mainly about the pancreas. And now we know there's lots and lots of organs that get into the act. One of the big ones is the muscles down here. If you're not moving the muscle, it's likely to be a risk factor. That's why being sedentary is a risk factor and can contribute to hyperglycemia, especially in somebody who's eating more quantity or more high carb foods than their body can handle. Whereas if they were walking 30 minutes most days, it doesn't need to be out there running like Patrick, it could be walking. Even 15 minutes, even 10 minutes, it can lower the blood sugar because when you move these big muscles, whether it's arms or legs or any other big muscle in the body, that muscle will pull the glucose in from the surrounding bloodstream, lowering the insulin resistance and helping to prevent or to lower the hyperglycemia or the high blood sugar. I won't say much more about all of these other than, the gut, the brain, all of it gets involved. And certainly for somebody who has type 1 diabetes condition, you're probably a lot less likely to see the brain for all of us doesn't do well if the blood sugar gets out of range, but high blood sugar particularly, it can be a leading cause of kidney issues, and the kidneys are involved in this regulation of glucose normally under normal circumstances. So there's a lot more we could talk about there, but I don't think I have you all day, so I better keep a move on. Rita, can you remind me, are we supposed to finish at my time 1:15 or 1:30? What time are we supposed to finish?
1:30.
1:30. Oh, good. So, good. I think we're okay time-wise. So, of those diabetes self-care things, eating and moving, you've already heard are important. It's helpful for people to test their blood sugar, but it's also important to get this hemoglobin A1C, and that's usually done in the doctor's office. And it's also important to get these annual lab exams. So checking your blood glucose and then what are called annual tests. An eye exam, because the eyes don't like the high glucose environment, and the nerves in the feet are often affected by high blood sugar or diabetes that's not ideally controlled. And then those cholesterol checks is part of a fasting lipid profile, and the kidney blood tests are another important piece. And who had, let's see, diabetes complications? I think that was you, Suleiman.
Yes, please. Excuse my pronunciation, but try my best. Diabetes complications can be either long-term or short-term. Most happen because high blood sugar damages blood vessels and nerves over time. Long-term complications, heart and blood vessel disease, increased risk of heart attacks, strokes, and poor circulation. Kidney disease, damage to the kidneys that can lead to kidney failure. Eye disease, damage to the retina that can cause vision problems or blindness. Nerve damage, often affects the feet and legs, causing numbness, tingling, or pain. It can also affect digestion and other body functions. Foot problems, reduced sensation and poor circulation increase the risk of ulcers, infections, and in severe cases, amputation. Short-term complications, hypoglycemia, blood sugar drops too low, causing shakiness, confusion, or loss of consciousness. Diabetic ketoacidosis, DKA, a dangerous buildup of acids called ketones due to a lack of insulin. Hyperosomalar hyperglycemia state, HHS, severe dehydration combined with extremely high blood sugar. Other risks, people with diabetes may also be more prone to gum disease and infections.
Thank you. Thank you so much, Suleiman. The being prone to ketoacidosis is generally speaking only in people who have type 1 diabetes, so not something you would see in type 2, but all those others that you mentioned, Suleiman, the vision, nerve damage to the feet, putting people at higher risk for heart disease. It's this, when diabetes is in the picture, it's an equivalent risk to somebody who's already had one heart attack. It's a risk factor that big for heart disease. So, yeah. The good news is, having worked with hundreds or thousands of people who are in this zone, including some whose blood sugars were very, very out of control, out of that range, is that it is possible to bring them, even with diabetes, back into the range of diabetes health. And depending on how long somebody's had diabetes, it is possible to, in some cases, reverse it or move it into pre-diabetes. And anytime you can get the numbers, the blood sugar numbers, a little more near normal, it's pretty helpful. And so whatever's happened in the past, it can get better. Foundations of health, you know that many of these things you assess in some of your clients are part of those foundations. And for diabetes, it's these diabetes self-care 7, the eating, being active, moving, medication. It's also the capacity to know enough about their own numbers to know how to solve problems, like, why am I feeling woozy after I do XYZ? Is it my blood sugar going too low or too high or something else? Getting those annual checks are very helpful to kind of seeing what's happening in the big picture. And then coping, the idea of stress management and having a stress management toolkit that individuals can use. And it might be their faith. It might be that they just love to move to music. It might be, that they know about meditation and guided imagery, whatever those things are. We're going to look quickly at one more person. This is an individual who I would just ask you, her name is Violet. I would ask you to kind of identify which factors do you think helped Violet move the needle towards better health?
I was angry with myself because I knew what to do, and I did not. So since diabetes is a preventive disease, I did not do what I needed to do to avoid it. I would come home on the days that I didn't exercise, and I would sit on my couch and just stare at the television. And I would have projects that I need to do, and so much stuff that I was just like, yes, I know I need to do those, but I had no desire to do them. I had bouts of depression, and so with that, how do I get over how do I manage the depression? And at that time didn't share that I was depressed, and still deal with the work and diabetes. My first step in managing was to start with the physical aspect that comes with diabetes that can help you eliminate your diabetes. And I chose that because I like exercising, and I figured I'd probably be able to get a more return on my investment quicker, and it did. The physical activity, as I said, was gave me an awesome return on my investment, because not only did it help me decrease the insulin, it gave me mobility back. It also helped me lose weight, but not so much as pounds, but inches. And people were telling me, "Oh my goodness, you've lost weight." And I was like, "Thank you, but the scale is not saying that." But yeah, I could still feel it in my clothes. So it gave me that internal push, that said, okay, keep on this path, because it is good for you. So pray on it, think about it, choose a path. Okay. One path is really, really easy. You don't have to do anything. The other path is you need to, and you can take it slow. Look at you, because this is your body saying, hey, you're not taking care of me anyway. So how can you take care of you so you can be the better you? There's just so much out there for you. So embrace it and do something about it.
So what do you think? What do you think helped her move the needle towards better health?
Her faith, movement,
and movement. Yeah.
Movement, and also food preparation. That's something that was not highlighted, but you could see the difference in her intention and the way she prepared food. And I wanted to refer to that earlier when we were discussing diets and just regional factors. And I think that's a huge component to preventing, maintaining, or reversing diabetes is the food preparation.
Yeah, sort of being willing to devote yourself to some amount of grocery shopping or getting the ingredients, and then some, being willing to cook at home. I mean, that alone is a big help, because most fast food is ultra processed food.
Yeah.
Yeah. So yeah, and you noticed how the movement helped her physically, but it also helped her emotionally, I would say. The other thing that Violet was part of a 6-month program, University of Virginia, and I believe it was in her case also the group, the learning environment, and then the group support that was pretty helpful to her. And you didn't see that there, but that's my hunch too, of something else that was helpful to her. So they haven't yet added what I think needs to get added here to the self-care skills, these mind-body skills, be it, prayer, meditation, guided imagery, there's yoga, Tai Chi, those kinds of things. But they're all important. And for now, these other 7 are the ones that are the official ones. It's Cynthia's list that would have the mind-body skills added. So how can you help? Well, you probably have your own ideas about that already, but given where we are time-wise, I'm going to just share a few of mine. That judgment-free zone that you offer as a coach can help people process their feelings. It can also help develop a sense of, sometimes there's even grieving from past efforts that needs to happen, and just by being in silence and holding space with people, that can happen. But the coaching, process overall can help to build some self-compassion moving forward. Many of these things that we know, the process of coaching can involve, from identifying the new wellness vision to what steps would help me towards my long-term goal, and how can I have plan B. Small enough steps to build confidence can be very helpful, and you know those already. And then feel free to come and take a look at this one. We're not going to look at this video today, but the FISB model that you were introduced to, I think in class 1 or 2, David Emerald himself was dealing with diabetes, and his doctor said to him, well, you learn all this stuff about coaching and business. Why don't you do it for your own self? And the FISB model, I think, came from that. I'm going to scoot over these two for now. And I'm seeing some things in the chat, but I think what I'm going to do is take you to your breakout, which will happen here in a minute. Just know that it's ideal for a client or a patient if they've got not only their primary care doctor and maybe a hormone specialist like an endocrinologist on their team if they actually have type 2 diabetes, but also a registered dietitian and a nurse. Those are covered by almost all insurers for people who have either kidney disease or type 2 or type 1 diabetes. And there are teams more and more who are composed of health coaches on those teams as well. So I think we talked about all of these. Just remembering, identifying where somebody is stage of change and being appropriate with them there, even if they're in ambivalence about making change, very useful. It may not seem like I'm getting them to action, but it's still very useful. So I'm going to skip over the refer and just invite you to think about if you were starting a class series. I think you've been introduced to group coaching already. Yes?
Yes.
Yep. So if you were starting a first class, let's say it's going to be a 6 or an 8-week series, and you're going to offer it maybe with a diabetes educator, coach, educator kind of thing. These would be some of the things that might be helpful to have in that first class. What are the community guidelines we're going to operate on here? And it might have to do with how we're going to speak to each other, how, going to take turns, those kind of things. Might be about the coaching process. It might be giving them an icebreaker that would perhaps be a mind-body skill or a movement or something like that to help them kind of come together and connect. We'd like to give you a moment to set up, and I'm going to take a quick look at time, maybe about 4 minutes in a breakout. Notice the name of your group. If you're in group A, you'll be developing what would the community guidelines be that would be helpful for a first setup class series, kind of thinking that through and coming up with something to share back when we come together. And if you're in the second group, it'll be group B will be either coming up with an icebreaker or mind-body skill that you could do in that first session that would allow people to come together. So sound okay? Kind of know what you're being asked to do?
Yeah.
Back. Okay, so I'd love to hear maybe just a 1-minute version from Group A with the community guidelines. What 2 or 3 things kind of rose to the top would you want to include with community guidelines, sort of the ground, not rules, but ground guidance as a group is starting?
So our group, we spoke about not giving advice and just realizing that everyone's obstacles or struggles with this could be different. One person may struggle with movement while another one struggles with eating. So not advising, but being empathetic and active listeners.
Lovely. That's probably the most important one. Yeah. Anyone else from that group have one that sort of rose to the top? Or was that the main one?
Yeah, exactly. That the main one is everyone has his own journey, like avoiding comparing and yeah, not giving advice. We got the coaching philosophy from Georgetown, I think, very well, like to refrain from advice.
Nice, nice. Yeah. Sometimes also asking people not to talk over each other. Yeah, but that could all be part of
Yeah,
it. And sometimes on that, giving a method if they recognize it is advice that they're wanting to add in, to ask the other person before they ask the other person, to sort of set it up that way that if you have advice you're just bursting to give, you might recognize, okay, do my best to self-regulate and recognize it is advice I'm thinking of here, and then ask the other person or ask the group, would you like to hear the idea that's coming to mind for this or for that? And by naming it as part of the group guidelines up front, you remind everybody to say no when they mean no and yes when they mean yes. And that can be helpful because so many people get into people pleasing and say yes when they don't really need it or want it. So not giving advice is a great rule. And sometimes it's helpful to have a backdoor way to do it that's also somewhat safe. Great. Thanks. How about
amazing.
the mind body group or icebreaker group who had what were you thinking? Is that Carrie or Sheila, or Vicky or Dee Dee? Who's speaking for that group?
Well, I will start. We came up with some thoughts, meditation, breath work, just breathing exercises, visualization, intentional movement with maybe some soft music, something that will get, everybody, the blood flowing. Maybe as sort of a game to build relationships among the group to sort of break the ice. We did one at our first meeting with the cohorts, and that was very fun. And we just created. It was organic, and it was nice. It was gentle, but it was very meaningful.
So lots of good ideas there, from potential meditation to some kind of mindful movement that allows for, in that case, for relationship building too.
Right.
Nice ideas. So yeah, as you got to know the people that were coming into your group, it might help further what's the word I want? Make that even clearer, which of those would allow for creating safety, but also give people a felt experience of something experiential and ideally connecting maybe to others. Great. Well done. So just sharing about one other, case example. This was a hour-and-a-half class that we did for 8 sessions called 8 Weeks Towards Wellness. And we noticed some different things. You don't get the same capacity to take an individual all the way through the same things that you're recording for your practicum, right? The vision, the values, the focus, the long-term goal, the short, action steps and helping them overcome barriers. But as a group, they're also learning from each other. And many of the participants, when we surveyed them, this was one of probably 4 groups that we ran at the University of Virginia like this. They often preferred, to do things with a small group together rather than just dyads within that. So we found that if we listened to that and we did it that way, things take longer, right? So there's learning as we go. From I guess it was 5 cohorts, it was a while ago, things like the mood scores improved, the Beck Depression Inventory and the WHO or World Health Organization 5-question questionnaire were the things we used to measure, and they got better with everyone. The weight loss, the blood sugar were variable between people. Many did lose a bit of weight. Some did improve blood sugar and blood fats, but not across the board. And since the groups were small, it wasn't statistical in our case. The activity and their capacity to move quicker, which is another measure of, sorry, that's my little timer, did improve. And this was the feedback from one of them. If it was available every week, I'd do it forever. So unfortunately, it does take some energy to run a group, as you all will find. And just as we wrap here, I guess it's time to wrap. There are gaps in healthcare that health coaches can fill. And more and more, as that's recognized that chronic disease is really the epidemic in America, health coaches will have a place. And there are places like the Diabetes Prevention Program that hire health coaches. This is the entire curriculum for how you run a group like that. In case any of you want to start one, you could probably, Suleiman, start one over in Kuwait and use this as your curriculum. You'd need to have a few partners probably, but that could be done anywhere in the country. Does require keeping some data. And just that there's lots and lots of resources in these two places, the cdc.gov and the va.gov with the Veterans Administration. This is a nice book that brings together some current thinking on metabolic health, but also coaching. And yeah, so I think with that, just be in touch if I can be of assistance going forward. And I'll be here if you have a question or three. If we didn't get to, I think we actually didn't hit on you, Carrie. Did you have a definition for prediabetes to kind of round us out at the end?
Sure. Prediabetes is a condition where blood sugar levels are higher than normal, but not yet enough to be diagnosed as type 2 diabetes. So it acts as a serious warning sign and significantly increases your risk of developing type 2 diabetes, heart disease, and stroke. One of the key factors is its reversibility, that you can reverse or delay it through weight loss, physical activity, etc. Usually does not have symptoms, and the underlying cause is when your body starts experiencing insulin resistance.
Thank you. So that's a nice sum to maybe where we started and where we came back to. Thank you for that. So if anybody has questions, I'm here, but otherwise it's been a delight to be with you, and thank you for being so participative today. Makes it more fun for me.
Thank you,
Thank you so
Cynthia.
much,
Have a
Thank
great
Cynthia.
you.
Thank you,
Very,
Cynthia. Thank you,
very good
Cynthia.
information. Thank you.
Okay, I'd like to wrap up the class before we move on to closing out. And I want to be sure I give you the second key word. The second key word is self-care. The second key word is self-care. And I do want to thank Cynthia because the information was so very important. And if you all have some questions, you can stay on, and that would be wonderful.